Thank you for giving me the time to speak here. Today at this symposium, I'm speaking about cholera as a neglected disease. Somehow this is a surprise, as probably most of you may know that epidemiology as a discipline started in 1853 with when Dr. John Snow did follow through on a cholera epidemic in London. His investigation resulted in taking away the handle from the pump in Broad Street. Whilst the cholera epidemic declined rapidly after removing the handle, John Snow himself is one of the first to point out that the epidemic was already in rapid decline and that therefore the link between the decline of the epidemic and the removal of the handle of the pump may not have been as strong as was suggested. After further investigation, some years later, it is shown that the well in Broad Street could have been contaminated through an old cesspit that had started leaking into the well. Now, 160 years later, cholera is still with us. In many places, especially on the African continent, cholera has become an endemic disease that continues making victims, though in recent years mortality has declined significantly due to faster and better treatment. On the preventive side, with the exception of major infrastructure interventions, the efforts to diminish or contain cholera outbreaks appear not to make the impact that is expected. Despite almost 20 years of cholera intervention since the major outbreak amongst the Rwandan refugee populations around Lake Kivu, the DRC is still facing cholera. In some areas, cholera has become a fact of life. One may wonder why this is the case. When we look at the cholera interventions that are undertaken by non-governmental organizations in Eastern Congo, it seems as if cholera can be prevented rather easily. Chlorination of drinking water and health education, focusing on household hygiene and drinking water, should, according to the plans, suffice to stop the spread of cholera, or at least diminish the transfer rate. Unfortunately, there's little proof that such approach has any effect. Though, on the upside, it should also be acknowledged that there is little proof that such approach has no effect. The simple answer is that we don't know. And maybe it is the lack of clarity that makes cholera maybe it is this lack of clarity that makes cholera a neglected disease, and thus worth discussing today at this symposium. In August 2013, Didier Bopanga from the Université de Franche-Comté in France and Oxfam started working on a proposal that aims to enhance the understanding of the disease. As we are both focusing on the DRC, the information that has been accumulated in the Eastern DRC served as our main source of information. The proposal is in line with the multi-sector plan of the government of the DRC. The main aims of this plan for the period 2013 and 2017 are reinforcing of surveillance of the general cholera epidemiology, applied research and information dissemination, reinforcing preventive measures, promoting sustainable interventions around drinking water, sanitation and hygiene, provision of medical care to cholera cases, and reinforcement of coordination and communication. The proposal itself looks at centralizing cholera-related information in Kinshasa, analyzing the information as well as disseminating of this information to the relevant stakeholders, notably the Ministry of Health and the Cluster, a grouping of WASH-related NGOs and UNICEF, as well as the University of Kinshasa. DJ and I came to the conclusion that such initiative was needed after having analyzed the available information. I will now give a short overview of the information we took into consideration. For most interventions, little or no reliable epidemiological data is available. An outbreak of cholera is reported by a cholera treatment center or reported through the weekly statistics from the health zones. Information about the exact location and evolution of the epidemic in time and space is often not available. In many ways, a cholera outbreak is a moving target, and actions and impact need to be interpreted with a good understanding of the manifestation of the disease and the expected epidemiological patterns in mind. This knowledge is most of the time not available, and obviously the absence of viable impact indicators makes it hard to evaluate interventions on their effectiveness. We already spoke about that this morning when there was made reference to what kind of indicators should we then follow. The transmission of the disease is not very well understood by the intervening parties. The focus is mainly on improving the quality of drinking water and household hygiene practices, while other routes of transmission are not targeted. It is interesting to mention that 2 evaluations in Burundi showed that bathing in open bodies of water had a major correlation with cholera manifestation. It's not that difficult to imagine that bathing and ingestion of contaminated water during bathing may be closely linked. In addition, the cholera statistics from the DRC show almost systematically a possible correlation between proximity or contact with surface water and cholera. Fishermen, herders, and people living nearby the shores of lakes show an increased probability of contracting the disease compared to other categories that are less likely to be in contact with surface water. Whilst it is generally accepted that in endemic areas, 75% of the infected cases do not show any clinical symptoms, the interpretation only takes into account that the cases that show clinical symptoms. But if 23% of our population has shown clinical symptoms, does that mean that only 23 out of 100 have been in contact, or that the whole area, 100% of the population, should be considered as having been in contact with Vibrio cholera? Obviously, the latter assumption would provide a different perspective on the epidemiological patterns, as well as the immunological aspects that come with the disease. Relatively little is known about the reintroduction of cholera into a population. 2 aspects appear to be of importance. First is that areas that benefit from proper wash services appear to be prone to outbreaks as soon as the services are interrupted. Statistics from the town of Kalemi in eastern Congo, as well as Uvira, show an increase of cholera cases in the periods following such interruptions. This appears to indicate a permanent presence of Vibrio cholera in the ecosystems and contact between the sources of transmission and the population as soon as the services are interrupted. A second point is that although survival of the Vibrio cholera, the main agent of cholera in the alkaline waters of Lake Tanganyika, can be up to 3 weeks, little explains the occurrence of the infectious dose, which is as high as 1 million Vibrios or more. Most of the solutions that are proposed to reduce or avoid transmission of cholera are based on voluntary behavior changes in the population. This approach is vulnerable as there is insufficient evidence that the sought behavior changes will indeed protect people from contracting the disease. It is possible that the credibility of such promoted behavior changes will erode, and with that the credibility of the intervening agents, if indeed people still keep on contracting the disease. In this respect, it is interesting to mention that the 2 epidemics in Burundi were effectively stopped by the Burundian army, prohibiting the population from entering the Ruzizi River, and that Jon Snow removed the handle of the pump. At least 3 examples that did not target voluntary behavior change, but effectively closed off access to contaminated sources. A last main point is that in the DRC, cholera-related information is dispersed. Despite the fact that interventions have been undertaken for over 20 years, the learning from these interventions is not available to the intervening or other interested parties. Most information remains within one organization, and it is hardly used to improve or better comprehend the problems and the dynamics of cholera in the DRC. The proposal that resulted from the assessment we undertook in August last year aims to improve the information availability to all relevant stakeholders in the DRC and to improve the ability of the intervening parties to target and follow through their actions. To achieve this, it is proposed that a team of 2 staff, supported administratively by Oxfam, but managed through a steering committee made up from the Ministry of Health, the cluster, the University of Kinshasa, and Oxfam, undertake the following initiatives. collection of existing cholera data, analysis, reports, projects, etc., in order to provide an overview of the current state of cholera knowledge and activities in the DRC. The development of a network of cholera specialists, academics and practitioners that could be available to support the cholera elimination policy in the DRC. An initial cohort study for 2 periods of about 8 months in a limited area that is prone to cholera outbreaks in order to understand changes in the environment and behaviors of people that are conducive to cholera transmission. In close collaboration with the Ecology and Control Unit of the Faculté de Médecine in Kinshasa, developed research proposals that aim to clarify the cholera dynamics in the DRC, help to improve the targeting of cholera hotspots for the guidance of implementation of the oral cholera vaccine in the public health strategy of cholera elimination, and participate actively in both the multi-sectoral and cluster coordination in order to inform the Center about existing cholera-related initiatives and to share information obtained by the Center. Eventually, this Center should contribute to the necessary information for the yearly evaluations of the multi-sector policy. Hence, this proposal tries to link the different institutions that have an interest in cholera in the DRC to improve the targeting of various interventions and to centralize and disseminate cholera-related information and learning to the relevant stakeholders. This initiative is referred to as the Cholera Information and Research Center and could become a central addition in the cholera network in the DRC. Thank you.